Μιλήσουμε τον κύριο Foss με το θέμα του, το βλεφαρόσπασμο.
Thank you. And thank you for the invitation to speak here and allow me to escape the English summer. I'll be talking on the subject of blepharospasm. And usually when a surgeon talks about patients, he does it from a surgeon's perspective. But rather unusually, one of my patients was quite a renowned novelist, and I shall include her perspective in this, as she wrote extensively about her disease and her treatment. And you can find it on the internet if you want to Google it. Blepharospasm is essentially involuntary eyelid closure, but it's often associated with other abnormal movements, particularly around the mouth. And although the classic description in the textbooks is from 1910 by Meg, it's such a characteristic disorder, it must be known about since the earliest of times. And you should make a clear distinction to be made from blepharospasm from hemifacial spasm or facial nerve irritation. With facial nerve irritation, you classically use smile, but with blepharospasm, it's a curling of the upper lip, like disdain or disgust, and it's more like a spastic face. And this is quite in keeping with what we know about the pathology of the disease, where most of the pathological changes are found in the basal ganglia or the anterior cingulate gyrus, and it's part of the emotional brain. So you like the expressions is sort of episodic emotional expression, and unfortunately the expression is one of either disdain or disgust. If you look at the blink reflex, it has two clear components to it. There is silencing of the levator muscle to raise the lid, and then there is spasm of the picularis muscle to cause the lid to shut. And you can stimulate the blink reflex by stimulating the supraorbital nerve, and if you do that, the silencing of the levator muscle is the more sensitive of the two processes. Blepharospasm is sometimes distinguished from apraxia of eyelid opening, but I'll suggest that are simply that's very sensitive. They are simply ends of a spectrum, apraxia being a mild form of disease, a bit like this, and blepharospasm being a severe form of disease, just like the emotional range from disdain to disgust, form a continuum. And I'll suggest that most patients are probably somewhere near the middle. The mainstay of treatment is botulinum toxin injections, but unfortunately, there are a number of patients who are resistant to the injections, and they pose a difficult clinical problem. In the United Kingdom, most cases of blepharospasm are treated by neurologists, and therefore they resort to drugs as their second-line treatment if injections don't work, and surgery is used as a last resort. The huge list of drugs that have been used for this condition testify to the fact that none are particularly successful. So going back to our index patient, Candia, she got blepharospasm really quite severely, and she became functionally blind. And she wrote about her experiences, which was covered in our national newspapers. The impact on the disease on her was severe. Her husband left her, I didn't put that on the slide. She was a liability in the kitchen. In fact, she managed to burn the house down following a kitchen accident. She couldn't cross the road safely, couldn't go out unaccompanied. But in addition to being physically isolated, it was also socially isolating too, because the expression on her face put people off, and people tended to avoid her. As a novelist, her passion was reading and writing. She had to give up writing completely, and her reading was reduced to 15 minutes a day. She went to see various neurologists, and she tried botulinum toxin, and it failed. She got no benefit from it. So she then tried on 3 of the drugs on that long list. She got no benefit from the drugs, but she did get the complications, and she developed grand mal seizures, so she stopped the medication. So this brings in the role of surgery for blepharospasm, and the most widely done procedure, the most widely credited paper is Anderson's paper, looking at stripping the picularis muscle from the upper lid, or myectomy. He claims that 90% of patients are benefit from this procedure, but I think those effects are exaggerated, and nobody else claims such a high success rates. And I've personally seen very little benefit from myectomy alone. The other procedure that has been tried is brow suspension. Brow suspension also has its problems. I remember in training when I was at Moorfields Eye Hospital seeing a patient who had a brow suspension, having lots of problems. This brow suspension hadn't helped him open his eyes. He was still functionally having severe blepharospasm. In addition, he was getting severe headaches because the frontalis muscles were fighting the picularis muscles. And his suspension was done with Merstin mesh. And due to the spasms, the wounds had gaped, the mesh had become infected, and he was having pus oozing from his forehead. It wasn't a happy scenario. And I would argue if you can do a brow suspension, but when you're using fascia lata, at least you can treat that with antibiotics and avoid one of those problems. Candida wasn't the first patient that I'd come across, and I developed a surgical plan for these patients, trying to address the two separate components of the blink reflex. Clearly, the myectomy would expect to deal with the Blepharospasm, and the brow suspension would deal with the later silencing, and therefore it seemed natural to combine the two operations, but it's a lot of surgery, and the idea of it done sequentially. First of all, doing the orbicularis strip, waiting about 4 to 6 months for the patient to recover from that, and then if they were still having problems, proceed with a brow suspension. As will become clear, the surgery is a major undertaking and is not free of risk. And it should also be pointed out that every patient undergone the surgical plan required botulinum toxin afterwards. So the surgery is an adjunct to the injections and not a replacement. Quite a few patients with blepharospasm have other disorders, most commonly progressive supranuclear palsy, and these patients I have simply avoided. Before Candida come, I reviewed the first patients I'd done, which were 13 patients with blepharospasm and one, as we'll show, probably a mistake, with hemifacial spasm. And 4 were lost to follow-up, 2 dead, 2 couldn't be found, so that's 10 patients to review. Now, assessing the outcome of surgery is quite difficult. I was reminded by a writer in England, Samuel Johnson, who wrote that alcohol makes men extremely pleased themselves, but not necessarily very pleasing to others. And I think the same thing sometimes be said about surgery and surgeons, that surgeons are often very pleased with their surgery, but their patients are less satisfied. We devised a questionnaire, and with 8 questions, each phrased positively and negatively, to be scored on a 5-point scale, to be fairly quantitative, and also 2 free text boxes. To describe what was best and what was worst about the surgery. These were the results. The ceiling performance on the scale was 40. The 2, hopefully this is going to be a laser pointer. That patient was the hemifacial spasm who was quite happy with the surgery, but didn't think he got much benefit from it. The other gentleman in the series was this gentleman here, who was extremely unhappy by the surgery. He had been poorly counselled, thought the treatment was experimental, didn't like the scars on his forehead. But in my defence, at least in the box, there's anything you can't do now, but you could do before, he wrote nothing. So at least on paper, he wasn't worse off, but clearly he wasn't better off. But most of the patients clustered strongly at the top end of the scale, suggesting they're getting significant benefit from the operation. Those 8 patients, these are their free text comments, which are again all extremely positive. So the conclusion from that was that the expectation of doing this surgery, I was hoping to make maybe a bit better, but some seemed to have got really quite substantial benefit and seemed to basically got back to a normal life. In the series, all of them had myectomy first, and none of them were happy with the myectomy alone, and all proceeded to the brow suspension, confirming the impression that myectomy alone confers little benefit. At the time I did that review of those patients, none had problems with exposure. That's no longer true. One patient has had problems with exposure. As part of the treatment, had the brow suspension cut. The keratitis cleared up, and she requested and has had the brow suspension repeated, and she's doing fine again. And again, the caveat that I've limited it to patients with pure blepharospasm and not patients with other conditions. And for the Candida was not part of that series. I gave her the copy of the results of the first series of patients. She agreed to undergo the surgery, and this is the words of afterwards, in her own words, the results of the surgery. Thank you.
Thank you very much.